Good morning. On behalf of the Health Disparities Unit of the Social and Behavioral Research Branch, I would like to introduce our talk and conversation today. Racial inequities in health and what can we do about them? I'm pleased to introduce you to Shameka Thomas and David Williams. Dr. Shameka Thomas is a postdoctoral fellow in the Social and Behavioral Research Branch in the Health Disparities Unit at the NHGRI Intramural Research Program. She is an alum of Spelman College and received her Ph.D. at University of Miami in medical sociology and race relations. As a postdoc here at NHGRI, her research will focus on the ethical and social implications of reproductive genetic technologies among Black women. I'm also honored and pleased to have my friend and colleague, Dr. David Williams, here to speak to us this morning. Dr. David Williams is the Florence Sprague Norman and Laura Smart Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at Harvard T.H. Chan School of Public Health. He is also a professor of African and African American Studies and Sociology at Harvard University. Dr. Williams is internationally recognized social scientist focused on the social influences of health. His research has enhanced our understanding of the complex ways in which socioeconomic status, race, stress, racism, and health behavior and religious involvement can affect health. The Everyday Discrimination Scale that he developed is the most widely used measure of discrimination in health studies. Dr. Williams has played a visible national leadership role in raising awareness levels of the problems of health inequalities and identifying interventions to address them. He has received numerous honors and awards. He was elected to the National Academy of Medicine in 2001, the American Academy of Arts and Sciences in 2007, the National Academy of Sciences in 2019, and he's also received many distinguished contribution and awards from various professional organizations. Dr. Williams has been involved in the development of health policy at the national level in the United States over 20 years. Dr. Williams, we are pleased to have you here at the National Human Genome Research Institute. And the last thing that I would like to say about Dr. Williams, he was a member of our council between 2011 and 2013. Welcome back to NHGRI. Dr. Williams.
Thank you so very much for your kind words of introduction. It's always great to be introduced by a friend and colleague. Sometimes they do such a great job of promoting you. My mother would have been pleased to hear the introduction, but it's an honor and privilege to be here with you and to share some of the research on a really timely topic today. I'm going to jump right into my talk. I'm going to share my screen. So that you will see my PowerPoint slides and want to leave plenty of time for conversation today. I want to begin my conversation by talking about deaths of COVID-19. That is the pandemic that we're currently in the United States. And as you can see, the death rates vary markedly by racial ethnic status, with African Americans and Latinos having overall higher death rates. And these are deaths through September 15th. Another way to think of these differences is that if all racial ethnic groups had died at the same rate as white Americans, 20,800 Black Americans who died would not have died, 10,900 Latino Americans would still be alive, and 700 Indigenous Americans would still be alive. So that's a kind of concrete way to think of what we mean by there have been disparities. Why do these disparities exist by race ethnicity? COVID-19 is not unique. This is true for most leading measures of health outcome in the United States. And the first thing I would say, why do we see them, is there are large inequities in health by socioeconomic status in the US and elsewhere. Income, education, occupational status is the single biggest predictor of variations in health globally. And there are large racial ethnic differences in socioeconomic status in the US. The differences are larger than most Americans think. Here is data, 2019 report from the US Census Bureau showing median household income by race, and you can see it's 70,600 for whites, 41,000 for African Americans and Native Americans, 87,000 for Asians. I like to translate these data in a way you can't miss the point. So this is the same data. I'm just standardizing now on the household income of whites is $1. For every dollar of household income white households receive, Asian households receive $1.23. This has to be contextualized by Asians is the population highest rate of immigrants. Almost 70% of Asians in the US are immigrants, and they've come to the United States with high levels of human capital, markedly higher levels of college completion, for example, than any other population. More importantly, Asians have more persons contributing to household income on average than other groups. So if I'd done a per capita measure of income, whites would have the highest per capita measure of income. But let's look at the historically disadvantaged groups. For every dollar of household income white households had in 2018, Latino households had 73 cents, and Native American and African American households had 59 cents. Do you know what is stunning about the 59 cents figure for Blacks in 2018? That is identical to the Black-white gap in income in 1978. I did not misspeak, you heard me correct. 1978 was the peak year of the narrowing of the Black-white gap as a result of the anti-poverty policies of the 60s and 70s and the civil rights initiatives of the 60s and 70s. That gap was narrowed to 59 cents. And in 2018, it is 59 cents. Has it been stable over time? No, it hasn't. It fell throughout the decade of the 1980s from the 59 cents figure, and it didn't get back up to 59 cents until 1994, and it's been a penny up and down since then. The important point, though, is that these racial inequities are larger, much larger than most of my students and most Americans think. And as bad as those racial inequities look, they dramatically understate the racial gap in economic status. What do I mean by that? Well, income captures the flow of resources into the household, but it tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth, which is home equity and other property and your savings and check-ins, investments, and so forth. And here is the latest data from the Federal Reserve Board on racial differences in wealth. For every dollar of wealth that white households have, Black households have 10 pennies, Latino households have 12 pennies, other races have 38 cents. So you can see there are large striking differences in income and wealth. And when you lack wealth, you are often a paycheck away from being homeless, a paycheck away from being unable to feed your family. When my career started, most researchers thought that racial differences in health were simply a function of differences in income and education and wealth. And that if you looked at persons of different racial groups at the same level of income and education, race wouldn't matter. We now know that life is more complicated than that. And to illustrate that, I'm going to show you national data on life expectancy at age 25 by level of education. But age 25, the average white person will live 5 years longer than the average African American. If we look within whites by education, whites with a college degree or more education live 6.4 years longer than whites who have not finished high school. Importantly, the gap by education and income is larger than the gap by race. Within African Americans, we see the same thing, a 5.3-year gap between African Americans with a college degree or more education and African Americans who have not completed high school. So this is an important point because in the United States, we almost uniformly focus on racial ethnic differences in health. And what we see here for life expectancy is true for most health outcomes, that the gaps by socioeconomic status, income and education, within each race is bigger than the racial gaps. Am I suggesting we should only focus on socioeconomic status instead of race? No, that's a false choice. We need to look at both because a much more complex pattern emerges when we look at both. Because what we find is that at every level of education, race still matters. So white high school dropouts still live 3.1 years longer than black high school dropouts. And that gap widens as education increases, 4.2 years between black and whites with a college degree or more education. And arguably one of the most stunning things I'm showing you today, and remember this is national data for the United States, not a sample, national data for the United States. The best of African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college, lower life expectancy than whites who have finished high school. So what does these data tell us? There is something profound about income and education that matters for your health regardless of your race. But it also says there's something else about race that matters profoundly for health even after we've taken income and education into account. And just to show you this is not a uniquely US phenomenon, I'm going to show you data for the United Kingdom, COVID-19 deaths in the UK. And here is the age-adjusted death rates for black males compared to white males in the UK, 4.2 times higher, even larger than the US. For Bangladeshi and Pakistani, 3.6 times higher. For Indian males, 2.4 times higher. And even when we statistically adjust for income and education and housing tenure and health status and urbanicity and so on, there's still a 90% increase, 80% increase, elevated risk of death for blacks or for Bangladeshi and Pakistani in England. If you look at data for women, you see the same thing, four times higher death rate for black women in the United Kingdom. And you see, again, adjusted for all of the socioeconomic and demographic factors, there still is something else about race that matters profoundly. Just one point that I will come back to later. In the UK, they have access to the National Health Service. Everyone has access to care, suggesting that access to medical care is important, I think very important, but it is not the driver of these inequities in health. And even if you had access to care and if everything else stayed the same, we would still see some striking patterns. So what else could be occurring? And I have been part of a group of researchers for the last 20, 25 years, has been asking the question, could racism be a critical missing piece of the puzzle to understand the patterning of racial disparities in health? And I think when we think of racism, it's important to distinguish individual behavior and beliefs versus institutional structural discrimination, because it's the institutional structural that is the most important, but it all matters. Let me give you an example of institutional discrimination. We are in election season, so I picked an example linked to voting. How long did Americans stand in line to vote in the 2012 presidential election? Here is national data for the US, averages. You see, on average, whites stood in line 12 minutes, African Americans stood in line 23 minutes. You can see the differences for other groups. Importantly, these differences in waiting, none of them reflected the behavior of local precinct workers. Local precinct workers did not tell blacks to wait in line. They did not delay them in any way, did not treat them badly. Instead, it was linked to where you voted and what was the budgeting and space constraints. What were the local administrative procedures? How many voting booth areas did you have for the population? How many precincts? What was the level of staffing? So my point is, it was policies and administrative procedures, but that none with the people who administered them, treating everyone equally, but nonetheless, we saw striking differences in voting. So let me give you the example of one example of institutional racism in the United States. In my TED Talk, I said it's the secret sauce that drives racial inequality in America, and that is residential segregation. We don't think about it. No politician is talking about it. It's a striking legacy of racism, but it has powerful effects, and I'm going to show you the empirical data today. John Sell, a historian at Duke University, wrote a book about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in the early 20th century in South Africa looked across the Atlantic, saw residential segregation in the US. That's where they got the idea from, and said, brilliant, we can implement that in our country. Importantly, he argues that segregation by race was one of the single most successful domestic policies of the 20th century in the United States. What does segregation do? And what does segregation have to do with anything you say? Well, think with me about segregation like a toxic emission produced by an industrial plant. It's often imperceptible, but as segregation appears, valuable resources that predict health disappear, like quality schools and safe playgrounds and good jobs and healthy air and water and safe housing and good access to transportation, even access to high quality medical care. Let me give you some empirical evidence. Here is two of America's most eminent sociologists, William Julius Wilson and Robert Sampson, both colleagues of mine at Harvard. This is a 1995 publication. They studied 171 largest cities in the United States and said because of residential segregation, there's not even one city where whites live under equal conditions to blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. But that's a 1995 study. Where are things now? Here's data from Dolores Acevedo Garcia from Brandeis. This is a February 2020 publication. She has characterized every county in the United States by the level of opportunity at the neighborhood level. And she has 24 different indicators of opportunity. And these are examples of the some of the 24 indicators: the quality of elementary schools, the quality of early childhood centers, the rates of home ownership and income levels and environmental quality and access to green space and healthy food outlets. And this is what she finds. In the 100 largest metropolitan areas in the United States in 2020, 2 out of every 3 black children are growing up in a very low or low opportunity neighborhood. That is also true for 58% of Latinx kids and 53% of Native American kids, in compared to about 1 in 5 white and Asian kids. If we look at who are in high opportunity neighborhoods, we see almost 2/3 of white and Asian kids are in high opportunity neighborhoods, compared to about 1 in 5 African American and Latinx kids. This is the driver of inequality in the United States. These differences in opportunity at a neighborhood level even shape racial differences in economic status. So here is data. This is David Cutler, until recently the Dean of the Social Sciences at Harvard University, one of America's leading economists. He, using a national study of black and whites, he's able to show statistically with very rigorous analytic procedures that if you could erase segregation, you would completely wipe out black-white differences in income, education, and in unemployment, and reduce black-white differences in single motherhoods by 2/3. All of those stark, striking differences that we are aware of are produced by access to opportunity at a neighborhood level. That's a 1997 publication. You want more recent data? Here's a 2018 paper from another Harvard economist, Raj Chetty. He has done a phenomenal analysis. He has taken, has gotten access to census data from 1989 to 2015. And he's asking a question about the intergenerational transfer of economic opportunity. And he finds statistically adjusting for the income level of black and white households. So comparing black households and white households that start out at the same income level, and says, what happens to the next generation? And he reports that in 99% of census tracts in America, black boys who start out at the same household level as their white counterparts are earning less income in their generation. Why? They live in neighborhoods that differ in access to opportunity. When African American boys live in neighborhoods that have access to opportunity, they do just as well, but they are essentially only 1% of US census tracts in America have such neighborhoods. So folks, when we talk about racial inequality in the United States, people often think of them as looking at a broken system. I would suggest we are not dealing with a broken system. We are reflecting a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. These are not accidents. These are not acts of God. They reflect the successful implementation of social policy, inequities by design. What does low economic status mean? It means that even in this pandemic, we are all Americans are in the same storm, but we are in different boats. Because when you lack income and wealth and resources, yes, there is the storm, but some boats are better able to weather the storm than others. And we see this so strikingly with COVID-19, that not everyone could work from home, and people who have low wage, non-salaried workers, they need to work to continue to feed their family when there is no income and no economic resource and no wealth to take care of them. And then we have research that documents that the lower economic status, that living in disadvantaged, segregated neighborhoods, combined with the exposure to racism, leads to markedly higher levels of economic stressors, of psychosocial stressors, of racial discrimination, of physical and chemical stressors. Let me give you some quick examples. This is some colleagues of mine at Harvard that have shown that people who live in areas of high air pollution are more likely to get severe cases of COVID-19 and more likely to die of COVID-19. So air pollution is a risk factor, and the poor and minority communities are at higher risk of air pollution exposure. Interpersonal discrimination is one potent type of stressful life experience. Vince mentioned the everyday discrimination scale that I developed. These are the 9 items. Just day-to-day little indignities, treated with less courtesy, less respect, receiving poorer service, people acting as if they think you are not smart, they're afraid of you. Little indignities. This is a slide that shows you there's been more than 200 published peer-reviewed studies globally looking at the everyday discrimination. It predicts higher levels of everyday discrimination, predicts incident metabolic syndrome, incident cardiovascular disease, incident breast cancer, type 2 diabetes. It predicts higher risk behaviors. It predicts a number of preclinical indicators of heart disease and other conditions. It predicts blood pressure. It predicts poorer sleep, quality, and duration. It predicts higher rates of multiple markers of subclinical disease like inflammation and cortisol levels. It predicts higher rates of obesity. It predicts lower levels of utilizing screening offered by a provider. It predicts higher rates of mental health. Just a sample, and there are many other measures of discrimination. These are just findings from the everyday discrimination scale alone globally. And that is just one kind of stress. There are so many other race-related stresses that populations face. And I'll give you another example of a paper published in 2018 in The Lancet with one of my former students, where we linked a database that had every police killing in the last 3 years and linked it with another database from CDC that had the mental health of the population in every state. And using a quasi-experimental design, we were able to show that every police killing of an unarmed Black male led to declines in mental health for the entire Black population in the state in which that occurred for the next 3 months. There was no effect for whites, and this was a specific effect. It was only police killings of an unarmed Black male that led to worsened mental health of Blacks. If the Black male was armed, there were no negative effects. So it suggests that it's the perception of unfair and injustice that creates the stress that leads to worse mental health. Here is another example of what many minority youth face. This is a study of a colleague of mine, Brandisha Tynes, looking at Black and Latinx adolescents, 11 to 19 years old, and those who have higher levels of exposure to traumatic images online of someone of their own ethnic group being beaten, arrested, or detained, or being shot by the police, have higher levels of PTSD and depressive symptoms. What research is documenting that all of these stresses, the psychosocial stresses, the economic stresses, the neighborhood stresses, the racism, and all of those things are taking a biological toll on the health of the population. There are different words used in the literature. Accelerated aging is one, premature aging is another, biological weathering. Let me unpack Geronimus's term, biological weathering. Imagine a drop of water falling up from the rooftop of the building you're sitting in to the concrete sidewalk below. If water dripped today, that's no big deal. But if day in, day out, week in, week out, month in, month out, there's a steady drip, drip, drip of water, that concrete sidewalk would become weathered. It would become eroded by the constant exposure to adversity. What research is telling us is that populations of color in the United States, your age not only captures how long you have lived chronologically, but how long you have been exposed to adverse stressful exposures, physical, chemical, toxic exposures, and therefore how biologically weathered you have become. And so in national data for the United States, we see at the same chronological age, African Americans are more likely to have high blood pressure, more likely to have diabetes. And I could go down the list of a broad range of chronic diseases. Studies have even looked at telomere length differences at the same chronological age, where African Americans are 7.5 years older than their white counterparts who are chronologically the same age as they are. And what does this all mean? Here is a study from New York City, 12 hospitals, almost 6,000 patients. Here are the comorbidities of all the patients who were hospitalized. 57% had hypertension, 42% diabetes, 34%, 42% obesity, 34% diabetes, 18% heart disease. In fact, only 6% of patients hospitalized had none of the comorbidities, and only 6% had one. So all of them, or most of them, 88%, had two or more. And we are looking at the conditions that put populations at greater risk. So I've talked about the problem. What can we do to reduce these inequities? How do we build community immunity for future pandemics? I would argue that fundamentally, we need to create communities of opportunity to minimize, neutralize, dismantle the systems of racism that have created inequities in health. What does that mean? I would say, number one, we need to invest in early childhood. This is a study from Chapel Hill, North Carolina. Poor kids, 80% of them African-American, randomized at birth to a high quality early childhood program, good nutrition, good stimulating environment, good access to pediatric care. By age 21, doing much better in health, better educationally, better vocationally. By the mid-30s, markedly lower risk of cardiovascular disease risk factors. Here's the systolic blood pressure differences between the intervention group and the control group. Moreover, these studies show that these interventions not only save society, not only are successful, but they save society money as well. What else do we need to do? We need to reduce childhood poverty in the United States. Here is data from UNICEF. The US ranks 34th in the world in terms of childhood poverty. A lot of our children growing up poor. Here is a powerful slide from UNICEF. Look at this far left example. This is the country of Ireland. The economy in the country of Ireland produces a child poverty rate of 42%. But after taxes and transfers, that's after the policy preferences of the society, it is reduced to 8%. And you can see other countries markedly reducing their child poverty rate by policies that they implement. In the US, the economy produces a child poverty rate of 24%. And after our taxes and transfers, it's reduced 1 percentage point. There's a lot that we can do. Here's a new report from the National Academy of Sciences that links strategies that we can implement to reduce childhood poverty in half in the next decade. And Nelson Mandela reminds us that there can be no keener revelation of a society's soul than the way in which it treats its children. What else can we do? Communities of opportunity need to enhance income and employment opportunities for youth and young adults. I don't have time to review the studies, but there are a lot of studies that shows providing low-income populations additional income, no health intervention leads to improvements in health. Overwhelming scientific evidence. I'm going to show you one study in detail. This is a study looking at the impact of increasing the state minimum wage above the federal level. And that leads to better birth outcomes and decreases in post-neonatal mortality. So we have good empirical evidence that these work. What else do communities of opportunity do? We need to build strong families. And there is a lot of concern in the United States about family structure, but sometimes we fail to think of what the key drivers are. We often focus on values. What national data tells us is that economic marginalization of males, this will not be politically correct, but I'm just reviewing the evidence, is a central determinant of the rate of female-headed households. So marriage rates in the United States for blacks and whites are positively related to average male earnings, and marriage rates are inversely related to male unemployment. So the question would be, if we created great employment opportunities for males, what would happen to marriage? Well, sociologist Jay Teachman in Washington State University has looked at that, looked at what has been the impact of military enlistment on young Black and white males. And in one study, he shows that active duty military service promotes marriage over cohabitation. A second study shows it increases the likelihood of first marriage. And a third study shows it leads to greater stability of marriage. So that, and all of these effects in these three studies were greater for Blacks than for whites, documenting that economic opportunities can in fact eliminate some of the large disparities we see in marriage. What else do we need to do? We need to improve neighborhood and housing conditions. We have high quality scientific evidence moving to opportunity, taking public housing residents, moving them to lower poverty neighborhoods. 10 to 15 years later, no health intervention, lower levels of obesity, lower levels of severe obesity, lower levels of diabetes risk. Here is another example, purpose-built communities. I'm going to show you East Lake, Atlanta, where the first purpose-built community was. African-American public housing project, very high crime rate, 90% of families victims of a felony each year who resided there. Very dilapidated housing, only 13% of adults gainfully employed, one of the worst performing elementary schools in the state of Georgia. Come with me to the villages of East Lake today, a collaboration between the local community, the Atlanta Public Housing, and philanthropy. There's been a 90% reduction in violent crime, high quality, privately managed housing. Half the residents qualify for public housing, half are at market rate. All able-bodied persons are employed. The school is one of the best performing elementary school in the state of Georgia, even though 60% of the students qualify for reduced price school lunch. It shows that it can be done. And purpose-built communities is providing free technical assistance to any community in the United States that wants to replicate their model. What else do we need to do? We need to build more health into the delivery of medical care. That is, ensure access to care for all. We need to also ensure access to the receipt of high quality care. I served on the National Academy of Medicine committee that produced the Unequal Treatment Report, and we have evidence of persistence of racial bias in medical care in the United States. We also need, in the delivery of care, to provide care that addresses the social context. The WHO asks, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? And we have examples such as the Medical Legal Partnership, where in a safety net hospital in the pediatrics unit, a local primary care provider can refer to a number of specialists, including on-site attorneys, to solve the problems in the lives of patients. What else do we need to do? We need to diversify the workforce to meet the needs of all patients. Here is a study published from PNAS just a month ago that showed between 1992 and 2015 of 1.8 million hospital births in Florida, when cared for by white doctors, Black babies are 3 times more likely than their white newborns to die in the hospital. Disparity cut in half when the Black babies are cared for by a Black doctor. Very sobering data for us. And it's particularly sobering because the American Association of Medical Colleges reported in 2015 that in 2014, there were 27 fewer African-American males in the first year of medical school than in 1978. We have a lot of work to do. And it's not enough to open the doors of opportunity, I emphasize. We need to create the pathways. We need to ensure that we are building the pipeline programs that everyone can walk through the gates. As Plato said, there is nothing so unfair as the equal treatment of unequal people. So what's holding us back? What barriers do we need to address? What's the elephant in the room? Why aren't we making more progress? I would say we face 3 main challenges. Most Americans do not know that racial inequities in health exist. I think COVID-19 has educated us, but in general, that's what the research has shown. Secondly, we need to develop the political will to address these inequities. And 3, we need to build empathy. My point about empathy comes from W.E.B. Du Bois. He was one of the great African-American social scientists of the last century. In 1899, he published a book entitled The Philadelphia Negro. He has a chapter in that book on Negro health. It has the statistics of the racial differences in health in Philadelphia in 1899. And he comes to the end of his chapter on Negro health. He says these profound words: the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And Du Bois continued, there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. What he calls the peculiar indifference, researchers today call the empathy gap. There's a well-documented racial in-group bias empathy gap. We feel more of the suffering and pain that happens to someone from our group than from someone from another group. And this is a recent review paper showing this empathic differences, not in self-reported, but in neural response, looking at how the brain responds to watching the pain of someone of your own race. And this is a sobering thing for us in the United States. Here's one study in the US shows that among white kids, there's no racial bias in empathy at age 5. There's a tendency at age 7, and it's pronounced by age 10. So we have work to do. I leave you with the words of Martin Luther King. True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. The inequities that we see in health are not accidents. They are not random events. They reflect edifices that we have constructed. And together, as one nation, we can come together and work together to, in fact, dismantle them. Thank you so very much.
Thank you so much, Dr. David Williams, for that phenomenal discussion and for this talk and your time. So for this part of this discussion, we're going to have a conversation with you regarding your reflections. And this will be about a 15-minute conversation. I'm going to ask you about 5 broad questions, and you can answer them based on your comfort level, but more so what you think may be impactful for us as scientists matriculating through these times. Audience, I ask that you send your questions to the Zoom Q&A, and they will be filtered to me as we conclude this 15-minute conversation. So you mentioned a lot about the added burden of race and also highlighting like the different components of health disparities as it relates to being in the same storm, but not necessarily in the same boat. I thought that was a really, really great way to metaphorically tie that all together. So my question for you as we reflect, can you describe your own reflection on what is it like or what has it meant for you to be Black in academic medicine as you navigate these waters?
You know, on the one hand, I'm living in the United States, and the United States is a nation of opportunity. But even academics face, I mean, no one is protected. If your skin color is Black, no one is protected. I don't want to tell a lot of anecdotes, but if you want to hear some anecdotes of what has happened in my life and in my career, I can remember starting my academic career as a professor at Yale University, and I'm leaving work at the end of the day, and I go into my car in the parking lot right next to my office, and the instant I open the car, there are police with bright lights in my face. Wow. And I say, I'm Professor Williams, what exactly is the problem? Why am I being harassed? And the police officer says to me, he is offended that I use the word harassed. And I said, I am offended that I am being harassed. I am leaving work. I'm in my parking lot, just walked out of my office. I'm heading home. What is the problem? And he told me, well, that there's a large, there was a Yale dining hall cafeteria right next to that building, and there was a large deep freeze, and there had been robberies there, and he is supposed to explore anything suspicious. So a Black man leaving with a jacket and tie, briefcase, heading home from work is something suspicious had to be examined. But it's just an example of these day-to-day indignities that people encounter. And I have many examples. I don't know any Black person that doesn't have many, but you encounter them. I think what has even been more challenging substantively is the work that some of which I have described. Mm-hmm. That even within NIH, I can use the term racism. Mm-hmm. I remember the first grant that I wrote was funded by NIH to study racism, race-related stress, discrimination I wrote it, and wisely, and this is good advice, before I submitted it, I had 2 colleagues read it.
Mm-hmm.
And one of them called me up, very supportive of my work, and he said, David, are you crazy? Because the study was entitled Racism in Health, a Study of Determinants. He says, do you want to get funded? Take the racism out. You're not going to get funded. And I went back to the paper, and probably the first version had the term racism 120 times. With the submitted version, it probably had the word racism 3 times.
Mm-hmm.
And a lot of places where it had used racism before, I used the term race-related stress. I did get funded. I'm thankful to NIH. I've been continuously funded by NIH for more than 3 decades. So it's an example, but it's an example of illustrating of even the freedom of talking with this. I'll give you another example, true story. I was part of a group of 5 external researchers working with multiple staff from NIH Institute. This is around 2003, to develop a meeting that would lay out a research agenda on racism. And we called ourselves the Racism and Health Working Group. And as we came close to actually having this conference actually take place, I think our NIH collaborators, we called it they said, well, what are we going to call it? And we said, well, it's the Racism and Health Conference. They said, no, we can't call it that. We said, okay, racial discrimination. Said, no, we can't call it that. And we academics were saying, why not? No, you can't. We want to keep everybody on board. And so we came up with racial ethnic bias. I said, great, racial ethnic bias is good. We could use that. Just to give you one more example.
Yes.
I remember submitting a paper to a major social science journal,
Mm-hmm.
reporting research on discrimination in health.
Mm-hmm.
And one reviewer said, this is 15 years ago, the term racism does not belong in a scientific paper.
Wow.
This reviewer went on to explain that racism is an ideological concept that cannot be measured. Fortunately for me, the editor said, disregard reviewers A's comments, but respond to the other issues. But I'm saying, so these things were not, it wasn't welcome to be doing work on discrimination. It is very heartening that when I started, there were 5 people in the world, and I could count on one hand, who was studying racism and health. And today, it's a global phenomenon, and we have evidence from around the world that these experiences of discrimination and these institutional mechanisms do matter profoundly for health.
Wow. Your answer is so profound, and thank you for walking us through, because you've highlighted the science, and it's so great to get to know the person and the process behind the science, right? And so as we're continuing to think back, you did highlight some books that you read, for example, the John Sell book, William Julius Wilson, The Philadelphia Negro by W.E.B. Du Bois. What other books were you reading during your PhD program or early career? What was going on in that time frame for you as you think back and reflect on your earlier research questions?
I would talk about two sets of books. I talked about John Sell's book as a historian, Massey and Denton, American Apartheid by Douglas Massey and Nancy Denton, 2 distinguished sociologists. Their book was very influential and led me with one of my former students, Dr. Chiquita Collins, to begin doing work on the relationship between segregation and mortality. And there are other people who, Palednak and others, had done work in that space, but it really persuaded me of the centrality of segregation to the inequities in the United States. Give you another story. It's around somewhere early in my career, somewhere around 1992, 1993, I am at a National Center for Health Statistics conference in DC, and there's a final panel after this 2-day meeting and those of us on the final panel, I was the Black person on the final panel, was to reflect on what we had learned over the last 2 days and directions for future research. And I remember saying that one of the priorities, this is 1992, 1993, one of the priorities for future research is research to document the role of racism in health. And I remember a gentleman putting his hands up and says, I think Dr. Williams is right that racism is important, but what he's calling for is impossible. We can never measure racism, And so it's impossible to study its effects on health. And I remember saying to him, if you ask me today, do I have valid and reliable measures that we could use? I would say no. But I said, we measure self-esteem. If we measure self-esteem, why do you think we can't measure racism? We just need to put our minds to it. And I went back to the University of Michigan, where I was an associate professor, and I put my mind to it. I read work by Joe Fagan on qualitative descriptions of discrimination in American society. I read the work of Philomena Essed, a Dutch scholar who has been studying African-American women in California, as well as immigrants from the Dutch Caribbean in the Netherlands, and documented that discrimination is not just the big things that occur, but it's the little day-to-day indignities. And I credit her with the idea of the everyday discrimination scale. That's where I got the idea from. Her book is entitled Everyday Racism. And I'm also thankful to acknowledge the meaningful support of mentors. I'm not self-made. Jim House at Michigan made a difference in my life. And secondly, and this is difficult to talk about right now, James Jackson. He was my mentor for my work on discrimination.
Wow. I see what that it means a
James
lot.
Jackson died within the last 2 weeks, so it's very difficult.
Yes, thank you for sharing that with us. And as we think about health disparities, particularly in NHGRI with genetics and precision medicine, how should we study the role of genetics in race and ethnic research? And what does that mean for us in regards to something with the history like eugenics, or understanding how it has been beneficial and harmful to study or include racial disparities in genetics?
Sure. No, this is a really great question. I have served in the Council of NHGRI, so I believe in science. I believe genetics is real, and genetics certainly is a factor that contributes to our health. The issue, though, is that there's been misguided research for a long time that has viewed genetics as the driver of group differences in health. Certainly who my great-grandparents are profound drivers of my health today. But the evidence that genetics, especially gene frequency differences, do not seem to account, given the genetic variation that exists within populations for the important group differences in health. But I don't think that genetic it should be dismissed without empirical evidence on the one hand, but I also think that we should have empirical evidence before we draw conclusions about genetics findings. It is not uncommon. I think Richard Cooper has shown this, had a wonderful talk where he showed this, that there are many researchers who look at a racial difference and adjust for income and education, and it still exists, and suggest that it's probably some residual unmeasured genetic factor. And I think with conclusions about genetics should be based on genetic evidence. The other really important point for me is one of the things I have said is that segregation has produced populations that live under different environmental conditions. Even genetics is not static. It is adaptive to environmental exposures. And if you're looking at groups living under different environmental conditions, you should expect to find biological adaptations to the environmental exposures. So I think that especially in the area of racial inequities in health, we really need to be paying much more attention to epigenetic differences and even intergenerational. There's some growing research that suggests that. There's some studies of the Holocaust and others that are documenting epigenetic effects that occurs intergenerationally. So I think we really should be paying much more attention to epigenetic patterns and looking at how do the distinctive social and environmental conditions lead to adaptations, including genetic adaptations that creates distinctive biological profiles.
Right. Absolutely, absolutely. So I have two more questions before we conclude this conversation, and I'm enjoying this, and thank you so much again. You mentioned that the system is not broken, right? That it's well designed and functioning. And so I wanted to know a little bit more about what does this mean in terms of policy or recommendations that you have for communities of researchers across the pipelines, and how we come to think of this well-functioning system structurally.
I think recognizing that it's a system means that our solutions cannot be individually focused and individually targeted. Yes, we need to raise awareness levels of populations in general, but we need to think that if we are dealing with systemic drivers,
Right.
then our solutions need to match the complexity and need to be structural and institutional and policy based to match the complexity of the challenges that we are addressing. I am particularly concerned of the large racial gaps in income and education, the large marked inequities in access to high quality education that exists for so many in our society. And I like to tell folks, this is about all of us. It's not about doing anybody a favor. There is a lot of evidence that these inequities in health, including racial inequities in health, are costly to the US economy. And they hurt our economic productivity as a nation. They hurt our global competitiveness. And I like to say to audiences, come with me to 2060. In 2060, Social Security estimates for every 2 people receiving Social Security, every person receiving Social Security benefit, only 2 people will be paying into the system. One of those 2 will be Black or Latino. Those kids in kindergarten today.
Wow.
If we are concerned about our future, our personal future, everything we do to ensure that those Black, Latino, and Native American kids have every advantage to benefit from what American society offers so that they can be productive, contributing members of society, that is investing in my future and my retirement. It's about all of us. When what we do to help the least of us helps all of us. And I think it's building that sense of community. This is not about them. It's about all of us. When we work together and improve access to opportunity, the research shows those strategies have benefits for society and improve a greater culture, country, environment for all of us.
Absolutely. Absolutely. Wonderful answer. Very precise. And as we conclude, this is my last question for you, Dr. Williams. I would like to know more about possible recommendations in regards to coping and well-being for many scholars who study heavy work like this, work that we're still trying to gain clarity around. How can we do a better job with our own self-care doing this type of work, or maybe some strategies you practice for yourself?
This is a great question. I mean, self-care is important. At the end of the day, we need to take care of ourselves. At the end of the day, there's more work to be done than the 24 hours in the day, and we need to practice balance in our lives. I want to talk specifically about maybe some of my work and the work of others that have pointed to some strategies that actually play a role, a protective role in health, in reducing some of the negative effects of stress in general, as well as some of the negative effects of the stress of discrimination. There's research. I'll give you a study. Gene Brody and colleagues in Georgia showed that African-American teenagers, they measured their discrimination levels at age 16, 17, and 18. By age 20, not age 40, not age 30, age 20, those African-American teenagers consistently high on experiences of discrimination at 16, 17, and 80, by age 20, they have a higher levels of stress hormone, epinephrine, norepinephrine, cortisol, higher levels of BMI, higher levels of CRP, inflammation by age 20. However, that relationship is broken among those who are embedded in supportive social networks. So the quality of social ties from parents, peers, and teachers protects those kids from the negative effects of the stress of discrimination on the biological dysregulation we are seeing at age 20. So the quality of social ties, there's a lot of research that has talked about that. There is work, there's a national study of Black Americans that shows the quality of religious involvement reduces some of the negative effects of stress on the mental health of African Americans. There's a study out of Canada I love a lot. It's a study that looked at 196 First Nation communities in Canada. And this is a population at the time of the study that had the highest rates of adolescent suicide in the world. And researchers went into these communities and found in half of the communities, as the group, they have the highest rates of adolescent suicides. Half of them have had no adolescent suicide in the last 5 years. So they started to ask the question, there's a lot of variation here, what predicts? And they were able to identify markers of empowerment, of fighting for justice, and of maintaining their culture. And those communities that were fighting with the federal government of Canada to maintain their fire and school systems and their healthcare and to fight for treaty rights and to have spaces in their community where they supported their culture. They found a dose-response relationship between the number of those indicators of empowerment and justice that the communities are fighting for and preserving their culture and the risk of adolescent suicide. The more of those the community had, and those that had all of them had no adolescent suicide. So it suggests that maybe there may be health benefits to the Black Lives Matter movement, that the protests and empowerment and doing something to make a difference may also be beneficial to our mental health, if not our physical health.
Absolutely. As we do, snap, snap, snap. That was a great answer. And thank you so much. So we're opening this up to the floor. And one of the questions that came through the channel wants to know a little bit more about COVID-19 and police violence, police brutality. And you spoke a little bit about this in your talk. And I would like, maybe you can expand on the current signs of the time as it relates to, as you just mentioned, Black Lives Matter, police brutality, and what does this mean in the context of COVID-19?
I mean, I think my point about COVID-19 and police brutality is thinking about, let me put it this way. If you look at the research on stress and health, one of the big things we have learned over time is that if we fail to measure stressful circumstances comprehensively, we underestimate the impact of stress and health. Yeah. And one of the points I'm trying to make is that in terms of measuring stress comprehensively, historically, we've looked at major life events, the death of a loved one, unemployment. We've looked at chronic stress at work and relationships and so on. But we haven't historically looked at racial discrimination as one type of stressful experience. And then even when we think of racial discrimination, we don't think of a news story of police violence as a source of stress. But now we are documenting that matters. That is adversely impacting the mental health because it makes all of us feel vulnerable. That it just randomly happened to this person, but that could be me. And so that is another way of thinking of a source of stress. Or the study I gave from Brandisha Tynes' work showing that the exposure to these videos online, and I had earlier published a paper with Brandisha Tynes where we had done the first study. She was the lead, she was supposed to post that with me, this was her work, but happy to work with her on it, was the first study documenting that experiences of discrimination online adversely affects the mental health of African-American teenagers in middle and high school. We showed and that the effect of online discrimination leading to higher depression and anxiety symptoms was independent of a global measure of adolescent stress and independent of discrimination offline. So we were documenting a unique contribution to online discrimination. I'll give you one other example we don't think about that matters for COVID-19. It's Deborah Umberson from University of Texas. Mm-hmm. She has raised the issue of what she calls community bereavement, showing that African-American kids are 3 times more likely than white kids to lose a parent by age 10. African-American adults are twice as likely than whites to use a spouse by age 60 and a child by age 30. So we have on our standard measures of life events the death of a loved one, but we are not capturing the intensity of that problem and how normative it is, how much more frequently African Americans are going to funerals is what I'm saying, because of the fabric of our community. These higher rates of death means that we are losing loved ones, and they are sources of income and sources of resource, and that all happened before COVID. What's the impact of COVID and this higher death rate that has just exacerbated this community bereavement on communities? I have some of my students. One of my African-American students told me last week, she has had multiple deaths within her family in COVID, and she's trying to focus on her doctoral work, but it is a huge challenge when we have the losses of that magnitude. And sometimes we recognize the death of a loved one, but we don't recognize the kind of accumulation and concentration of these stresses. And this is an important point. Some of the work I have done on stress, what we find is that African Americans and US born Latinos not only have higher levels of each of the individual stresses, but they have greater clustering of stressors. If you have one, you're more likely to have these multiple ones. And that's the added burden that is producing the weathering that I'm talking about.
Yes, the weather hypothesis. So thank you. We're actually at 10:30. And we thank you so much again for your time and just, taking us through this narrative of health disparities and structural racism. What can we do about it? Do you have any closing remarks, and maybe you can tie in some ways in which you're hopeful about these times for us as researchers?
I like to think, I like the words of Robert Kennedy, that each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. I have talked today that there are, in fact, mighty walls of oppression and resistance that is creating inequities on a broad scale in our society. Yes. But each of us can be a tiny ripple of hope, and together we can make a difference. Thank you.
Thank you so much again, Dr. Williams. And to the larger audience, thank you for your time and your flexibility with our talk today. We hope that you can carry this into your work throughout the week and throughout the remaining of the months to come. And we are going to conclude from this point. Thank you again. Enjoy the rest of your morning.
Thank you.